my great pleasure to introduce you to Steve Holland. He's Scientific Director of the National Institute of Allergy and Infectious Diseases in US NIH, and I'm sure you will really enjoy his talk.
Okay, so Antonio talked about organisms that are difficult to pronounce, and I'm going to prove that he is right. So when it was suggested that we should talk about the infections in primary immune deficiency, I went to the textbook and I looked at the first 400 infections, and I thought, I need more than 20 minutes for that. And so Clara said, that's fine, you take as long as you want. All right, so it is always good to start with something that I can appreciate. And I appreciate the fact that the very first Hippocratic aphorism reminds us that life is short, the art is long, opportunity fleeting, experience misleading, and judgment difficult. And nowhere is that more clear than in trying to understand primary immune deficiencies. So I'm going to try and talk a little bit about some of the infections. Obviously, we cannot cover all of them. There are way too many. But it is important that we began the study of what are now called inborn errors, but have been known as primary immune deficiency. We began that study precisely because of infections. And so we want to make sure that we appreciate that infections are more important than immunology, and that's where we should be working. So, which infections are we talking about? And in general, we are talking about opportunistic infections. So what makes an infection opportunistic? These are several features. They are disseminated, severe, persistent, fatal. But one of the most interesting things about opportunistic infections is they are almost always common. That is, they are the organisms that everyone encounters every day, and all of us handle perfectly well. It is when people don't handle their infection properly that we know that there is a problem, because we're all exposed and only a very few, as Antonio said, get sick. So I have examples because I think that they help me understand what is going on. All right, and these are all real cases. I don't know how to read, so I only have real cases. So 23-year-old athlete comes into the emergency room and says, there is a desk on my chest. Very good emergency room doctor says, no desk, no. And they say, you are an anxious girl, go home. And she does. And 2 days later, she is back. And now she is having fever and her oxygen is low. And they say, okay, I get it. And they admit her to the hospital. And over the next several days, she gets worse. They do everything right. She gets worse. Finally, after 8 days, they take her to a lung biopsy. Think for a moment, all of you who are here, you know how hard it is to get a surgeon to operate on a healthy 23-year-old woman. And she had to be very sick. And what did it show? You see here, this is a lung biopsy. You can count the number of alveoli. And you can see here, there is pus in the middle. And this was called a pus granuloma. And they looked at that and they said, this is bad. And now, 10 days after a healthy athlete came into the emergency room, it's a Saturday. It's always Saturday. And the pathologist gets the phone call that it is growing Aspergillus fumigatus. And the pathologist is now saying, what is it? And he starts calling around the area to find a doctor who will help him figure this out. So what is it? What is the problem? Right. You are all absolutely right. It has to be CGD, right? Because there is nothing else where a normal lung gets invaded like that with Aspergillus. So just to remind you what happens in chronic granulomatous disease, there are now 6 genes that are thought to be involved in the generation of superoxide. And these come together. 91 and 22 are in the membrane of the phagolysosome. 47, 67, and 40 are off in the cytoplasm. And Eros is the protein that takes 91 and 22 from the endoplasmic reticulum to the membrane. And that complex then is involved in taking an electron away from NADPH, transferring it to oxygen to create superoxide. That then is converted by superoxide dismutase into hydrogen peroxide. And then myeloperoxidase turns that into bleach. And that bleach is why white cells are white. Okay, that's a joke. No, that's not true. That's a joke. But that bleach is generated inside the cell. And that then helps to kill, through a variety of mechanisms, helps to kill the intracellular fungi or bacteria. And so mutations in any one of these genes create chronic granulomatous disease. And this young woman, right, a woman, 23 years old, she had a defect in P47 pox, which we heard about so well today in the morning session. So what happened? Once the diagnosis was made, it was easy to know what to do. And exactly as Antonio said, when you have a defect in innate immunity, you must consider that there is both infection susceptibility and disordered inflammation. So the key here is to treat with antifungals and prednisone, or methylprednisolone. And so we gave her the antifungals. She had problems, but after several months, she was back to completely normal, and she is now running several miles a day. She has 3 young children who are very cute. Why did this happen to her? What happened? So she was a very good daughter. Her father wanted to fix the garden, and he bought mulch. I don't know what you call it in Greek, but you know, the leaves and the dirt and the bark that you put on the garden to keep the water in. And she had been helping him spread that around. In the process, she inhaled a lot of the Aspergillus, and that's why she got this syndrome. So there are only a few infections that are common in chronic granulomatous disease: staph, Serratia marcescens, Burkholderia cepacia complex, Nocardia species, and Aspergillus. In North America, those are the 5 organisms that account for almost all of the infections. If you're not in North America, Salmonella, tuberculosis, and BCG are also very common infections. And then there are the infections at the bottom that are only for the people who have been working their tongues very carefully: Chromobacterium violaceum, Francisella filamoragia, Burkholderia gladioli, Granulobacter bethesdensis, and the Pacilomyces species. These are organisms that don't occur in any other setting than chronic granulomatous disease, almost always. Now, it is very specific though. Each organism is in a dance with its own host defect. So in chronic granulomatous disease, native normal lung can be invaded by Aspergillus. In Job's syndrome, which is shown here, due to autosomal dominant STAT3 mutations, their normal lung is not at risk of Aspergillus. And you can see these are typical patients with Job's syndrome. But once they get a pneumonia, and that pneumonia then gets treated perfectly normally, it's typical for them to have a cavity left over, as you see here, that cavity. And that cavity then gets invaded by Aspergillus, and that Aspergillus now is a problem in Job's syndrome. It is not a problem when their lungs are okay, only a problem after the cavities form. And it's a big problem because once the Aspergillus gets in there, it can cause bleeding, but it also does not always stay in the lung. And here you see the Aspergillus in one of the cerebral arteries and the subarachnoid hemorrhage that was fatal to this young woman. So same organism, different host, different manifestations. Invasive aspergillus is always abnormal, and it's always dangerous. There are very few diseases in which aspergillus can invade a normal lung. CGD is the one you need to know about. There are a few others. Okay, that's one. Two. There are other infections. So why do we spend so much time talking about chronic granulomatous disease? In part because it is the disease in which bacterial infections and fungal infections are so well defined, better than in many other conditions. So I want to just draw your attention to a rare, but I think poorly recognized infection in chronic granulomatous disease. These are easy. We all know how to understand that. These are also relatively easy. These are not so easy. And Granulobacter bethesdensis. I don't know if any of you have ever seen this infection or heard about this infection, but I feel bad. It's a really cool infection, let me tell you. So, Granulobacter. It's called Granulobacter because it causes granulomatous inflammation in chronic granulomatous disease. And it's called bethesdensis because it was discovered in Bethesda, which is where I work. And we discovered it in a man with chronic granulomatous disease who was in his 40s, who had been sick for 2 years. He had lost weight, he had chronic fevers, he had received lots of antibiotics. This was his mediastinum. This is an MRI of his mediastinum. You see these necrotic lymph nodes. Here you can see the histopathology showing lots of necrosis. Here you can see in the CT scan, in a section, he's got big mediastinal nodes that are necrotic. So this organism is very rare because it had never been identified before. But when something has not been identified, that means we never looked. And once we started looking, we found that it was present in many patients with chronic granulomatous disease, and like only a very few organisms, it can live quietly in the human for years at a time, and then only come back intermittently. So here in this man, in 2005, you see he had these 2 little spots in his spleen. In 2006, I couldn't see any spots. He was well. In 2008, he had numerous lesions in his spleen, and when we took it out, it was full of Granulobacter bethesdensis. And we know that his serology had been positive before that. So Granulobacter, it's always abnormal, and it can be dangerous. It's present at least in North America and in Europe. I don't know about in Greece, but I bet it is here. CGD is still the only disease in which it has been discovered, but that's because it's the only disease where we have looked. It requires special culture conditions, and it's very slow growing. That's why at the NIH, not in a hurry, at the NIH we could find it, but you have to wait for it to come up. And it either likes to grow on LJ media, Lowenstein-Jensen, which is the mycobacterial medium, or charcoal yeast extract, or some other minimal media. It can persist in patients for years. The isolates in Spain and Portugal are more virulent than the ones from North America, and we know this from mouse models as well as from the human experience. And here's what's important. 50% of patients with chronic granulomatous disease are seropositive for this organism. Even more interesting, 25% of normals are seropositive. Now, infections are discovered in normal people all the time. Think of HHV6, HHV7. What do those do? It took years to identify the clinical syndromes associated with them. Okay, 3. Helicobacter. Talk about organisms. It was only in the last 40 years that we understood why Helicobacter was so important in normal people. And these are almost all the species of Helicobacter. You want me to read them all? I can. No, okay, all right. But anyway, I know how to pronounce them. But Helicobacter is a funny organism, and it likes to live in the stomach and in the gut. Why am I talking about that here? Because there are these organisms called non-Helicobacter pylori helicobacters. This is one of the worst names ever. But there are all of these other helicobacters. Why do we need to know about them in the setting of primary immune deficiencies? Because Helicobacter bilis and organisms like it cause a characteristic disease in X-linked agammaglobulinemia. And this disease, as you see here, it is typically in the legs. It typically causes years of swelling and redness and pain. And then it begins to ulcerate. And you can see the ulcers here, which are painful, but not as severe as, say, pyoderma gangrenosum. And you see on the biopsy here, these are the organisms shown here in the tissue. It typically grows from the blood and from the stool as well. It is not easy to treat. It is very hard to cure. And this is one of the reasons that I think bone marrow transplantation is really something that we should be exploring more in XLA. These are chronic infections. They're slow to come on and very slow to resolve. Relapse is very common, difficult to treat. Bacteremia is there. And I can't explain why right now, I don't think it is the immune globulin level or the immune globulin components that are responsible. That is, BTK is doing much more than just telling B cells how to make antibody. That's important, Klaus, I get that, but they're doing more. Okay, last one. Thermally dimorphic yeasts. Now, most people do not think about thermally dimorphic yeasts, but I want to remind you why they're so interesting. They're dimorphic because they are one shape when they are living in the environment, and another when they're living inside of us. And so you see all of these organisms are more fungus-like when they are in the environment, and then become yeast-like when they come into us. There are only a very few of these organisms that are important, but Blastomyces dermatitidis, Coccidioides immitis, Histoplasma capsulatum, Paracoccidioides brasiliensis, Sporothrix schenkii, and then Talaromyces marneffii. Most of these are seen in the environment. Most of them don't cause too much problem. However, they occasionally do. And so Coccidioides mycosis, you do not have this in Europe, but you do have people who go to Las Vegas and to the Grand Canyon where they get exposed to this. And I have a patient right now that I take care of in Bethesda who lives in Cyprus, who got it while he was vacationing in the United States. They're here, they get sick. And in the presence of certain defects that control intramacrophagic killing, they get severe disease. This 22-year-old woman, you can see, had extensive disease in her right lung. This 16-year-old girl had extensive disease in her left lung and axilla. Both of these were fatal. What is going on here? So these organisms live in the phagolysosome. That's where they come in when the organism is ingested. Many other things live in this same place, the non-tuberculous mycobacteria, tuberculosis, salmonella, as well as all of these dimorphic molds. And then they lead to production of IL-12 and IL-23 that then leads to the production of interferon. And we know that this is the pathway because the genetic and functional lesions that are involved are shown here. The interferon gamma receptor, STAT1, STAT3, GATA2, IL-12 receptor, STAT4, and then very importantly, and I will then finish, of course, if you give people therapeutic antibodies to TNF-alpha, that makes them susceptible. But if they have autoantibodies to interferon gamma, that is a risk as well. And these autoantibodies to interferon gamma are seen often in people of Asian origin, East Asian origin, who have disseminated intramacrophagic infections. So if you're ever thinking about what commonly is called MSMD, you should always stop and think, could there be an autoantibody that is mimicking MSMD in this setting? So dimorphic yeasts are killed inside macrophages. Their host range, interestingly, it is not the same as Aspergillus. CGD patients do not get any of those infections. It's really about these inborn errors in the interferon gamma IL-12 pathway. Okay, so I'm done. There are many characteristic infections. Each disease has its own infections. Each infection has its own disease. Some are unique to a single disease. Some tell you about a pathway that you need to explore. But the microbiology is always important. Just like the gene identity is important, the microbiology is important. It tells you what you need to worry about, what your prophylaxis needs to be, and what to do. So I'll end here by reminding you of that first aphorism. Life is short, maybe my talk is not, but the art is long, opportunity is fleeting, experience misleading, and judgment is difficult. But just because it is difficult does not mean that we don't have to make judgments every time we see a patient. And every time we meet them, we wonder, why did that happen to that person at that moment under that circumstance? That's what makes our field so exciting. And that's what makes the study of the microbiology here so useful. Okay, thank you very much.